Welcome to the Scottsdale Top Docs Podcast, where we share a mission to improve access to care and prevention, as well as planning for the future. Our goal is to help people live healthier, happier, more informed lives. We believe that healthcare isn't a job, but a calling to serve, and the best care begins with conversation. Now on to today's episode. Hello, and welcome to today's episode of Scottsdale Top Docs Podcast. I have my guest today, Dr. Tammy Penhollow of Precision Regenerative Medicine here in Scottsdale, Arizona. Dr. Tammy, thank you so much for coming on.
Amber, it's a pleasure to be here. Thank you so much for the invite.
Yeah, I have actually had you on before, but not on this podcast. We had you on for Scottsdale Living, our other podcast, I think like a year ago. You are fantastic to talk to. So I had some questions that came up really organically, and I wanted to bring you on today to talk about the Wild West in medicine right now, stem cells. A lot of people don't really know what stem cells are from like the medical perspective. And it sounds to me like everyone is selling stem cells. Stem cells are getting confusing. They're getting confusing to the average bear and other medical providers. So, can you tell us a little bit about stem cells?
Yeah, it is a very confusing topic. And unfortunately, when it becomes the Wild West, there can be some unscrupulous players, some bad actors. So I actually devote quite a bit of a consultation with dispelling myths and setting the record straight on exactly what is a stem cell, who should be doing them, what kind of results can you potentially get from stem cells. So I guess the first thing to do is define a stem cell. I'm not going to do a neonatology anatomy kind of lesson, but in general, we talk about stem cells as being things that are within the body that can become cells. So when in embryonic stage, some cells become things like muscles and tendons and bones and joints. When we're in the pain management space or the musculoskeletal space, that's important. Others can become things like red blood cells, white blood cells, platelets, also very important. So I'd like to kind of limit it to that. But they can signal the body to go to an area of pain, an area of disease, and kind of turn on that light bulb and turn on the body's active response to start reducing pain, potentially reducing inflammation.
Okay. So Dr. Tammy Penhollow is also a DO. And I want you to talk about what is a DO. Where are you in medicine? You know, there are many levels of what people are looking for in healthcare right now, all the way from like a wellness provider and health coach to a naturopathic medical doctor, a functional medicine doctor, DOs, MDs, your orthopedic surgeon. Like, where does DO land, and what are your special areas of interest in medicine?
Sure. At this point, the easiest thing to say is that when you go to a physician, there are MDs, DOs, in England and other countries, MBBS. That is all equivalent.
Okay.
MDs and DOs and MBBS can go to any residency, have any surgical subspecialty, from urology to neurosurgery to family practice to whatever. So when you talk about MD, DO, MBBS, it's essentially a wash. However, the training for a DO is a little bit different. I'm a little partial to it. I do believe in my osteopathic roots. It was actually a branch originally, a physician, MD, was really kind of fed up with the fact that he had either surgery or pills
to offer patients. That's it. The only tools in his toolbox.
Exactly. And he's like, this is not right. Obviously, if you have an acute appendix and it needs to come out, there's surgery. If you have a horrible infection that is definitely bacterial, then we can give an antibiotic, but that's not everything. So he was disillusioned with the allopathic or MD model, and he formed the osteopathic model, basically saying that the body has the innate ability to heal itself if you put all these things into an alignment, literally alignment, kind of like in a chiropractic way, in terms of structure begets function. Imagine if you're walking all hunched over like this, do you think you can take deep breaths? But if we release the muscles, we realign the spine, I can take a lot bigger breath than that. So structure and function are integrally related. And that if you look at the person as a whole, holistic, where you're not the heart attack over in 4, you're Mr. Jones, a 60-year-old man who has a wife and 4 kids, and he's under a whole bunch of stress because the farm is just being repossessed. And he works from 3 in the morning until 12 at midnight, and he might get 3 hours of sleep. And he's got all these other psychosocial things that are going on that helps you address him and his root cause issues from the very beginning. So that's more of the holistic. And then obviously there are other practitioners who have really focused on holistic. And I know everybody has their role in taking care of patients. So I just do think that it's important for people to understand that there are differences in training. Medical school, 4 years, residency, 4 years, specialty, fellowships, or actually residency can be as short as 3 years if you're something like family practice, as long as 7 years if you're a neurosurgeon. So you've got after college an additional minimum of 7, sometimes, 7 plus 4, 11, and fellowship. So that's above and beyond what a lot of people will say, I've did my residency, but they're not a physician. So their residency may be that they spent a couple months with somebody and shadowed and got some hands-on, but it's completely different than the building upon building of years, and the sheer number of hours, completely different.
I love that you touch on that. I have a doctorate degree. I am not a physician. And I think that people are sometimes confused by the word. So in the 90s, when you heard, oh, I'm a doctor, it meant I'm a physician. Now, when you hear someone say, I'm a doctor, they have extra study in an area of interest that required typically a bachelor's. And then now you can go straight bachelor's, doctorate in many, many, many areas. It used to be bachelor's, master's, doctorate, PhD. And so, again, you can have a doctorate in so many things. In electrical engineering, you can have it in so many areas. So it just says, hi, I'm dedicated to advanced learning to be a doctor of something. A physician is of medical practice in a specialty area that required specific training. So, I cannot prescribe medications, and I have no interest in doing that. So if people say, you're not a real doctor, I say, I'm not a physician. I'm a doctor in my area, and that's it. So I think that it helps people to be able to ask that question. And so I don't want anyone to be scared of asking, oh, what kind of doctor are you? I think it's a really appropriate question. And I think people, if they do not have a doctorate degree or they're not a physician, by law, I'm actually required to make sure I explain that to people. I'm a doctor of physical therapy. I don't go around saying I'm a doctor and then leave it at that. Hi, I'm Amber Enright. I'm a doctor of physical therapy, because it helps them understand exactly what I learned. I'm only musculoskeletal, the end. So it's really important to understand where people are in their level of expertise when they talk to you. So that's why I had you on. I'm like, Dr. Tammy Penhollow, a DO, can speak to this. All right. So thank you so much. I really appreciate that. All right. So stem cells. Tell me about, why they're so sexy to people right now. And we're just talking specifically in this podcast about the kind that you inject. Let's just stick to that. You can touch on what kinds there are if you want, but let's just stick to the kinds that you can inject.
So it's kind of sexy right now because everybody is interested in extending their quality of life, their health span, not just their lifespan, looking at being vibrant and active throughout. And if you're an active person, you're going to get some wear and tear. It's going to form in tendon becoming weakened or potentially overused if you're slamming at the pickleball or whatever your sport is. Cycling, basketball is pick the sport, gardening. And you're going to get wear and tear on the cartilage that kind of cushions the joints. So trying to delay joint replacement, an alternative to joint replacement, if you're absolutely adamant, I do not want one, or I certainly don't want one now, and you have all this marketing that says, we can save your joint. You can stay out of the OR because we're going to inject these baby cells, these things that come from a placenta or the Wharton's jelly or the amnion. Who has younger cells than a baby?
Wow.
So you're thinking, whoa, that's really cool. Can I have some of that? And that's where it all starts to snowball. And
so here we go.
Here we go.
Okay. So where do stem cells in the United States legally come from? Where do legal stem cells in the United States come from? How do you get them?
Only from your own blood, bone marrow, only from your own adipose or fat. That's the only thing that's legal right now outside of a study, a registered study, not just, hey, I'm totally cool and interested in doing a little of this. Let me get some vials of this thing and do this thing. It's you are registered. It is applications. It is very strict. You can't just say, also, the studies going on where they're using cultured stem cells in Boston. I am not part of it, but I'm going to duplicate what they're doing. So I'm legit too. No, you are a registered patient within a study. So the only legal stem cells are in a study, or you can go to someone who is harvesting your own bone marrow or your own adipose fat, minimally manipulating. That's another thing. So there are some keywords: autologous, your own, minimally manipulated. It can go in a centrifuge. It can't have some things added, like to fat. There was an enzyme called collagenase. Collagenase forms a thing called SVF, or stromal vascular fraction. That was being used for quite some time until the FDA said, whoa, that's more than minimally manipulating. There's an issue here. So they shut that down. There's one county in California right now where people can use SVF. That's the only place in the whole United States until it goes through the appeals process. So minimally manipulating, meaning in a centrifuge, a single spin or a double spin, it doesn't matter, but you're not adding other stuff. You're not taking it and putting it in the freezer for a while. You're not warming it for a while. You're not freezing, defrosting, doing a cycle, something that's changing the composition of it. And you're certainly not taking it out today and putting it back in 30 days later after you've done some petri dish expansion. It's
like cultivation. I plant a seed and it grows, and now I can put more in you.
Right.
So that's not legal in the US.
Not in the US unless you're part of a study.
Okay. So fair. Now, people hear about other versions of stem cells, and the first time I ever heard of it, it was essentially a perspective of, they're taking cells from babies. It was actually a conversation about abortion. That was the first time I was hearing about stem cells and essentially how wrong it was. This was how it was kind of presented to me. So if you can imagine, from mine, it was a religious perspective that was like being discussed. And so where do other countries' stem cells come from? And do those get into the United States? Are those what people think that they're getting? Like, do they think that they're getting umbilical stem cells or amniotic stem cells? And if they think they are, do you think that they are? Do you think they're really getting what they think they're getting?
Absolutely not.
Not in the US.
Not anywhere. There's been so much work that's done on this that I cannot take credit for it. And I am happy to expand upon who has done a lot of work on this and takes these vials that different companies are peddling and promising doctors and advertising to patients. And they take out of each vial and they look at them under the microscope. No live cells, 100% dead.
No live cells.
They're dead.
Okay. Are those from other countries? Are they from our country? Are people trying to harvest cells in this way in the US?
That I can't give 100% answer on that.
Okay.
Most things come from a vial from out of country.
Okay.
What happens is you'll get a healthy mom who will fill out all this questionnaire, and that there's not a cancer, an active cancer, an active any of these massive diseases, and they consent to, after the birth of their baby, to be able to take the placenta and the umbilical cord and the Wharton's jelly, and they take it immediately and they freeze it and then process it, grind it down, do whatever needs to be done to expand it. But the moment you deep freeze it and the moment you do that, the cells die. It doesn't.
Oh my gosh.
Yeah.
Wait, so what about all these people who are freezing their umbilical cells?
Yeah, that's another topic, but I'll happily say that. Sadly say that a lot of people feel they were duped. There was a very recent New York Times article that kind of went into weeks and weeks of research that talked to different people from different companies, some now defunct, but they placed their stem cells into the bank in the hopes that if their child ever had something like a leukemia, lymphoma, something, that they would be able to reach into the bank, have the cells thawed, and then maybe save their baby or their child at that point, or the child's sibling if there was enough genetics. And unfortunately, many of the times the cryopreservation or freezing was not adequate, and there was contamination. There were no viable cells. There's people who are spending thousands and thousands of dollars a year to preserve them, to bank them on the off chance that they would need them. And now they're finding when they went to go to try to use them, there was a bacterial contamination or no
dead. Viable cells.
Right.
I don't know if you know the answer to this, but what's the percentage of people who do have viable cells after deep freezing? Or, are there any? Not likely.
Not likely. In the numbers where the researcher, Dr. Chris Centeno, did the research, he's done the hard work. And every time another vial comes out, he'll look at that under the scope as well. And let's just say you count 1,000 cells, there might be one or two, but certainly not enough that's going to say, let's go on to put it into the body and expect an effect for stem cells.
Okay.
So there may be some growth factors. There may be some anti-inflammatory cytokines. There may be some of those kind of things that survive. But are those what you're being sold? You're being sold stem cells, and there are no viable stem cells. And in the U.S., it doesn't matter if they were made in China or made in Wisconsin, they're dead.
Efforts like physical therapy pay great dividends when it comes to improving the range of motion, when it comes to improving the quality of a person's life.
You know how to change the way of life of people, which is a wonderful thing to do, to know you're doing that. Because I'm sure that without your help, I can do more than I thought I ever could. It's very important to have a way of moving around. Maybe you're not doing much of the moving, but you're moving. And I give you an A+. So I appreciate you very much. And that's the truth.
Okay, so great information and great start. So when people are being sold something that is essentially being told, here is a stem cell and it's not from your body, or stem cells, how do they know where it came from? Is there a label somewhere if it didn't come out of your body, like they didn't poke you with a needle, they did not draw anything out of your body or your bone marrow? Yeah. If they did not do that, how do I, as the consumer, look at it and say, this came from this country? Is there a label? Does it say made in China?
I've never held a vial in my hand because I won't let anybody into my office that sells that.
So it's just like, no.
So, but there is a vial. I've seen vial labels. It does say where it's made. It has a lot number. It has those things like, buying a vial of lidocaine for the dentist to numb your tooth before you get.
Or Botox or anything else. So essentially it's made by a company. The company has this. Well, like all medicines sometimes have essentially their brand And then sometimes a medication even is not just made by one source country. It can be made by two source countries, be the same drug and not be exactly the same, right? Like we do know that there are like a couple of countries that produce most of the world's pharmaceuticals, and they're not exactly the same, even if they're represented by the same brand name. Okay, so essentially that could happen anyway. If you're getting it from a vial, maybe ask some more questions and just don't assume that it's real stem cells. Is that where we're going?
I wouldn't
Or
even get it from
viable?
I would not get it from a vial. I
Okay.
would not go there. I cannot recommend that. Maybe in the future, we might have some potential. At this point, absolutely not.
Okay.
It's not legal.
Okay, good.
And my medical license is worth a lot.
Yeah, absolutely. I mean, because people need to know this information and it's very confusing.
It's very confusing.
Okay, so stem cells. Stem cells in the United States, something that didn't come out of your body, it's a no-no. It's illegal if somebody's selling it to you, no. But there are other trending terms, and now there's confusion about the trending terms. Regenerative medicine is a trending phrase right now. Everybody wants the fountain of youth. Even if we're just talking about joints, even if we're just talking about pain, even if we're just talking about how well I can move, how much regeneration is in regenerative medicine? What kind of changes do we really see on imaging? If I were to get cells that produce stem cells out of my own body and injected, and I specifically want to mention, you said if there were 1,000 stem cells and maybe there's 2 alive, what's the concentration that starts to make it effective? How do you as the provider know? I mean, if I'm 90 and I want to get a stem cell injection, you pull it out of my body and I've got 3, that you spun it and we pulled all the right things out. How do I know that that's an effective concentration?
Right. Dose matters.
Dose matters.
So that's where we're at in this field. Regenerative medicine is a hot name. It's in my business's name. It is something that I think wants to symbolize the fact that a person is looking at health span instead of lifespan. It's, can I turn back the clock a little bit? Can I at least pump the brakes? I think at this point, we're in a pumping the brakes. We're not in the, I get my own cells and all of a sudden I've got new cartilage in my knee when I was bone on bone.
Yeah, does that happen?
No, not right now with what we have in the United States. There is some exciting stuff going on outside the US, and I think it will come to the US. In fact, I know quite a few researchers who are taking their patients to very, very regulated, strict sterility labs. They could have been here, but they can't because of regulations. So in the Cayman Islands, for example, there's a big group that is throughout the United States that does take their patients to their facility in the Cayman. They will have the patient come, draw the stem cells, either adipose or bone marrow, and the patient comes back 30 days later and you've taken a 5 billion count and you've magnified that to 100 billion. So imagine, do you get more of an effect when you take 200 milligrams of Motrin versus 1,600 milligrams of Motrin?
And that's the comparison. So
Well,
where
that's
does
the
it become
dose.
effective?
So we're still looking at that. When we have our own, if I collect blood, it's a little different, but still take that blood and quantify it. Take the baseline blood and take the blood after you've spun it and look at the key things. Look how much the platelet count has magnified over baseline and look at the total dose. Right now, we're saying a great effective dose on platelet-rich plasma per injection is a gain of 10 billion cells. So if you take a baseline platelet count of anywhere between 150 and 450,000 and you have to go how many X to get that. So in the 10X, the 12X, the 15X, the baseline, and a total dose is the dose of the platelets times the volume you inject.
How do you find that as the provider? Please explain that process.
There is a machine, a hematology counter. Like in the lab, it'd be a complete blood count. So when you know that you've got a white count, a red count, the hemoglobin, hematocrit, and platelets.
And you get it instantly when you
There's
draw
a bedside, desktop bedside, I guess you could call it. It's not a small machine. It's probably the size of maybe this by this. And it takes it takes an investment on your part, and it takes regular maintenance and running the controls, et cetera. But you can get a printout right then and there. You use whole blood, you use the platelets. If their whole blood amount showed a really, really small platelet count, you hope you drew almost double, because you know that the
Got it.
efficacy is dose related. You give this many platelets versus you give this many platelets. You see the benefit only lasts about 3 months versus you see the benefit lasts a year and a half. So it's that important. And not a lot of people are quantifying platelets. So that was easy. That's easy because we have something that we can have in our own clinic. When you do stem cells, when I talk about mesenchymal stem cells, are the ones that typically have in utero developed into muscles, bones, tendons, joints, the kind we're talking about in musculoskeletal medicine, you don't have a same day quantification. You take a small sample of that which you are putting into your patient and you send it off, and it's put through different processes to culture and tell you a CFU per F. It is a number that's basically colony forming units per the measure. And the good or the average that I'm, looking for, I'm striving for is like 4,500 to 5,500. All but one of my samples has ever gotten that out of all of these. And that was in the 3,600. So that was one, but all the others have stayed in that range. So it's been then based on your technique. How are you drawing? How are you doing liposuction? What is your actual technique? What size syringes are you using? What anticoagulant are you using in the syringes? How many times are you twisting on and pulling, and what depths? So it's multiple depths, multiple this, all these things. And so we're honing this in to get this kind of a result. You need 2 weeks later to have known that you were in the 4,500 to 5,500 on your CFUs per F.
Wow. Okay. So this is a post-test anyway.
That
because
one
you can't store it to make sure. And then you give information to the patient about how effective it potentially could be. Or you're saying, I'm assuming that this is going to be effective, but you're checking in case it's lower.
Yes.
That way you could notify the patient, hey, we might need to do it again because your concentration of colony forming units, essentially stem cells that I pulled, based on how I pulled or based on what your body produces, which I don't know which one, I may need to do it again. So if you don't get the optimal outcome, this test says we might need to do it again, or that's as effective as one treatment is going to get for you.
Right.
Okay, that's interesting.
Yeah.
I had no idea how much weighed on the provider's technique. And I mean, of course, that makes sense.
Expertise.
I do none of that. I don't do anything with needles. I hate needles, all of that. I hate all of it. This is why I'm a PT and not anything related to what you do. Now, I can take a ruler and I can measure an angle. And if I hand that to you or anyone else, we may do it differently. So that makes total sense. And of course, there's provider error. There is provider difference. There is, essentially test, retest, offset that exists. So even with the best training, you could essentially not get the best draw.
Right. And that's why it's still the Wild West, is we're still trying to see what is the best. The dose matters, but now what is the dose? Well, in platelets, I can tell you 10 billion. The technique matters, and that's changing. It's evolving. I go to these conferences every year, probably 3 or 4 of them every year, and you get different things that are coming out of different centers and how people are using it. They're quantifying it, and we're sharing in a data biologics database. Literally, that's a brand of one, but there are other databases where people are saying it was this age, this sex, this blood draw, this quantity of blood was drawn. This is what I used for my anticoagulant. This is how I spun it twice, once. This is the total number of cc's where it was injected and where, not just in the joint, but now saying this is a functional unit. There's a meniscus, there's ligaments, there is bone. So we're actually seeing in an advanced arthritis now, you can't just put it in the joint and be done with it. And so many people are doing that, like you did with the steroid, just in the joint.
Right.
And you've got to use image guidance to get it there. But if we're talking now putting it in the bone, because from the bone comes the cartilage, And if we've got bone on bone and there's a bone marrow edema within that actually going to that area, you get a reduction in inflammation, you get an improvement in pain, you get an increase in quality of life with increased function. But if you just put it in the joint space, not enough. But 5 years ago, that's what we were doing. So this is an ever evolving thing. So you do need to know who's doing this and what kind of training they have and what kind of dedication to the advancement of the science they have.
Do you pull bone marrow cells?
I do.
You do. And is that typical that people choose that one over like the liposuction adipose cells? Are you a proponent of that? Because from the very tiny amount I know, the bone marrow cells are better. Is that accurate?
There was actually they're head-to-heads at each of these conferences where people say, I'm comparing bone marrow, and there's data being collected as we speak, comparing a bone marrow arm versus an adipose arm or a fat arm. And for different indications, say you have a bone-on-bone weight-bearing joint versus a bone-on-bone non-weight-bearing joint, the volume, do you put adipose in the spine? Well, is there adipose in the spine? Should you really be putting something there that can potentially clot into a small vessel in the epidural space, for example? So I personally will never put adipose in the spine. I can tell you that. I will never. So bone marrow is king for me in the spine. And I found that it gets great, if not equal, superior results to adipose. So in Scottsdale, I've tended to find that when a person says liposuction, sign me up, take as much, you take even more, please. Take more than I even need. Now I'd like a little bit more here. We have to be careful because this is not a medical liposuction. You're not going to get that perfect cosmetic result. And some of my patients don't have the body fat to harvest the fat. So they're a better bone marrow candidate. It depends on every situation. So to have that knowledge and to have the experience to say, in my hands, advanced knee does best with fat. Or in my hands, spine does best with bone marrow. And you can not just say in my hands specifically, because if you're part of the registry, you can look at the registry and say, you're in your 50s, you are a male, you have grade 3 osteoarthritis of the knee, so it's moderate to severe, that the data supports this many months of benefit with this percentage of a reduction in pain if you use this, or this many months of benefit and this percentage of reduction in pain if you use that. So you can have this kind of conversation with your patients, not just in my hands, but the collective.
Okay, so brilliant lead into the next question about essentially patients are constantly asking me, so what is the best? My insurance covers a corticosteroid injection. And from what I have experienced with my patients, and this is individualized to your insurance coverage, but you can potentially get a series of 3 corticosteroid injections. But sometimes there's issues with corticosteroid injections, even including potentially further degeneration from the continued use of corticosteroid injections. So some people like them. Some people say they didn't work at all. Some people are like, I did one and I was done. I got stronger. Like it really is so one patient, one result. But generally, most people find some kind of relief from them for a little bit of time. And I mean, I've had people say they felt better for a week, and some people say they felt better for 4 months, and some people say I never needed another one till right now when I have pain. And obviously, these are for pain. They're not fixing degeneration inside of a joint. So that means that when somebody comes to PT and they say, oh, well, I went to PT last year and I still have arthritis. I'm like, yeah, because PT doesn't fix your arthritis. It just helps you move better. XYZ, blah, 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 blah. We did this. Same thing generally with corticosteroid injections. Is that different for PRP or injectable stem cells?
Short answer, yes. I consider steroids as destructive. I consider platelet-rich plasma, bone marrow, or fat-derived cells as constructive, building. The corticosteroid disadvantages also include things like dysregulation of your blood sugars. If you're diabetic, they can go through the roof. If you inject it into a tendon, it can cause tendon rupture. You do see faster progression to severe osteoarthritis with continued injections, so many other things, the inability to sleep, the steroid, insomnia, the whole thing. So I don't believe in steroids. I used to do steroids in the traditional pain model all the time. And why do they say 3? Because some paper said that, if at an average dose of 80 milligrams, that the average person getting 3 is about 240 milligrams. And that's probably where we should have a ceiling, because above that, we really start to see these bad results that you've been talking about. But that's a massive dose. That's so much more than your body produces. We've got these teeny weeny little glands that sit on our kidneys called the adrenals. They produce steroid. So if they keep seeing steroid from the outside, they're going to say, why do I need to make this stuff? I'm done. So you can actually get the adrenal shutdown. So when you talk to your functional medicine people, all those, how many people do you know are in adrenal crisis or adrenal fatigue or adrenal, right? How many of those people did corticosteroids, or some people have to take daily steroids if they've got severe rheumatoid arthritis or ulcerative colitis, or it's an adjuvant therapy for many chemotherapies because it actually makes that chemo drug work better against the bone marrow cancer or whatever it is. So, it actually is contraindicated for me using your own cells. Corticosteroids, I will be 60 days. We don't touch you for 60 days when you've had a corticosteroid because its effects are anti what we want to do. It's preventing your body from mounting that response. And that's what these are. These are not these magic little cells. Please don't get me wrong and think that if I take something from your bone marrow and put it in your knee, it's going to say, ooh, I just got put next to a cartilage. I'm going to become cartilage. Or I just got put into a meniscus. I'm going to become a meniscus. It's that you put it in the right area and it's signaled the body to say, hello, this is the lighthouse speaking. It's time to mobilize. There's some damage here. We need to rush all the anti-inflammatory mediators. We need to rush the healing everything to this area. This is, plan A.
What is better, PRP or stem cells for essentially degenerative changes or bone on bone?
It's a tough question to answer with just one thing. It depends on the person. It depends on, do they have enough adipose that we can use fat? Do they have a history of maybe a former bone marrow cancer that I wouldn't want to use their bone marrow, but I'm okay to use their blood? And I've talked with the oncologist and they're this many years out and we don't have any issues. So there's that. There's also the dose. So again, a great 10 billion platelet dose PRP can be better than a suboptimal fat or bone marrow. So it also depends on the advancement. But in general, I can say a generalization. For mild, probably platelet-rich plasma. For mild to moderate, we're still probably platelet-rich plasma. We're moving into that moderate to severe, the 2 to 3. Then you're going to see some longer lasting effects adding in the bone marrow or the fat. If we're in the 3 to 4, it doesn't mean you can't use blood, but you may be doing it more frequently, like every 12 months or every 18 months, versus if you go for bone marrow or adipose and you go into the bone and you treat it as a functional unit, et cetera, then we may be looking at 5+ years. It depends.
Okay. Wow, a 5+ year. And then going into the bone, is that a different kind of procedure? So you're talking about people who just inject it into your joint versus another kind of procedure that's a little bit more detailed and gets you essentially to the surface of the bone. So
you're
through
within
cartilage,
the body. The body of the bone, using fluoroscopic C-shaped X-ray guidance to get to that area, correlating on the MRI to where the bone marrow edema is.
And
so it's not just sticking it in the femur, it's where the edema is. If it's on the medial, femoral condyle, then that's where you're at.
And for people who don't know, that's essentially like an X-ray that is a live movie for the doctor to use, right? Like you can see what you're going into.
Absolutely.
Okay, so all of that makes sense. Why are so many people doing essentially stem cell marketing right now? And who are the people we need to be looking out for? Please don't go there. And are there other words for stem cells that are being used that the public should kind of be questioning if they're really selling a stem cell that shouldn't be marketed versus the same kind of technique that pulls your own cells out of your body that does pull some amount of concentration of stem cells. Who is the provider? What kind of provider is really qualified to do this? I mean, I know there are, although I hate saying it this way, but dentists that do Botox. They're, in my hometown, the doctor that did Botox was the urologist. Great man. He was wonderful. Fantastic with the needle. I mean, he was.
Right.
He's the only guy that did it in my hometown, very small place.
He was trained.
Yeah, he was trained. So how do people know that because these are actually expensive procedures, generally speaking. People are paying sometimes thousands of dollars at a time to get both PRP or stem cell injectables for one joint, for one treatment. So it's not a little bit of money. They're investing in it, hoping for a really good outcome to essentially avoid surgery. They're taking money out of their own pocket. This is not covered by insurance right now. So how do I know if I'm going to the right place? How do I know if this is the right provider? And what happens if I sign up and I'm like, I'm going to Dr. Tammy Penhollow's appointment. She's going to do this for me. And then somebody else shows up to do it.
Great questions. When you're calling around, you can say, do you use autologous cells? Autologous means from my own body.
Okay.
Can I get a injection on the same day? I don't think I'd recommend that. You don't know if you're optimized. That's part of the deal that I now know when I draw that bone marrow and that I send it the way that I've been drawing it, that I'm going to get the same results I am because I previously optimized my patients. They've been on an anti-inflammatory diet. We've detoxed them if they're super sugar, super alcohol, super high fat, super all these things, because that translates to what I draw. And you are then putting inflamed cells into an inflamed body and you don't get the results. So getting a injection on the same day, did you stop your non-steroidal anti-inflammatories? NSAIDs poison the platelets. Motrin, naproxen, Aleve poison the platelets. So if you're drawing my blood and I'm concentrating platelets that are not effective. The growth factors are impaired. They're under the influence of the NSAID. They're not going to perform the way we want them to. So do you use my own cells or do you use something out of a vial? Do you do the procedure on the same day? What type of optimization do you have? What type of characterization of the platelet-rich plasma or the adipose or the bone marrow? Do you do cell counting?
When do I find that out?
When you're making your phone calls saying who you're even going to get the appointment with, and then who is doing it. Is it the doctor, or is that a medical director for a clinic that it can be another variously trained person that is the technician? And do you do fluoroscopic and or ultrasound guidance for these, or are they blind? So all of this matters, and you are the consumer. You are the one who can narrow down when you're making these phone calls, and those should be the tops. And then you make an appointment, and then you have that conversation. And is it a 15-minute appointment? Are you actually seeing the doctor for that 15 minutes? Is it a 1-hour consultation and you're diving deep into the history, even how you eat, what is your alcohol, tobacco, et cetera, intake? Let's look at the images together. Let's see what there is. And there's a physical exam. You don't stay fully closed sitting like this, having a conversation for an hour. Mm-hmm. How do I know where the targets are?
So essentially you're ruling people out with your appointment, saying this person's not really a great candidate for this. Or this person would probably be a good responder in this many days. So you're doing that on the intake, not just going in and selling someone something.
Right.
Okay.
I don't want to put my name on that. Not everybody's a good candidate. A person that is a good candidate is someone who wants to also partner with and invest in their future, their health. So we're working together to optimize them so that they can get these kind of results that they desire and they want. So we even talk about what is it you want to be? Are you wanting to be a competitive pickleball player? Are you wanting to be a very active mom, dad, granddad, etc.? Where are your goals? Because that helps you fine tune. Are we going to do both knees at the same time? Even though this one's a grade 2 and this one's a grade 3, would less downtime for you be better? Are you an in-season athlete? platelet-rich plasma, bone marrow, and fat are not great in season. It puts you down for some period of time. So then do we need to use another modality like shockwave? And that's when we're optimizing you, getting your anti-inflammatory eating, et cetera, et cetera. So there are a lot of things to consider. On the question of who else should be doing this, I have some very strong opinions that it should be people who are doing training specifically in regenerative orthobiologics, and not just somebody who's taken an online course or somebody who's read some books. It's active because it's ever evolving.
How do I know? Is there I know that for most physicians, you can go to their actual board and you can look up their license and make sure it's good. How do you know for something like this if they have the appropriate training?
You want to look for things right now that are big and very respected are the Interventional Orthobiologic Foundation, the IOF. You want somebody that's gone to TOBI, the Orthobiologic Institute. These are hands-on, multi-day, latest cutting-edge research, scientific
Advanced training.
And
with testing at the end?
These do not. There is a competency in regenerative medicine that the American Society of Interventional Pain Physicians, you can get certification in musculoskeletal ultrasound.
Mm-hmm.
Those are good to have. It's not a necessity. I mean, if you've done 150 exams and you can answer the questions here, it might help in the future should this become something where insurances want to say, I will only pay for a procedure that's been done by an RMSKUS.
Mm-hmm. Right. The musculoskeletal ultrasound professional.
Yes.
It can be a variety of professionals.
Yes.
But essentially an injectionist that's a doctor that has gone through the training that's guided by this ultrasound feature that says, I'm getting this exactly where it needs to go.
Correct.
Okay. Well, I really think that you've done a really good job of explaining to us like kind of these really big pitfalls that are going on in this trending topic of stem cells. It definitely is something people need to pay attention to. Not just for the legality of it, but obviously for the protection of what they're spending on it. You know, if I had not understood this, I would probably still think that my patients are getting something that comes out of a vial that works for them. And so people do ask, like, do I go to a different country to get this? I know people are asking these questions. Now, I have no idea. So this is why I bring people like you on. I'm like, you got to talk to your doctor about this. And there are still a lot of facilities and hospitals that do not talk about stem cells. They don't. They'll talk about PRP. They'll talk about corticosteroids all day long. And they'll send you referrals for a bunch of different providers. But at the end of the day, if you're in pain and you're seeking something like this, you need a professional that can answer these kinds of questions and is going to do so in a very direct way. Say, I want to follow the rules here. We're not doing anything shady. You're not getting stem cells from Mexico or China or Shanghai or anywhere. We are pulling these from your body. These are the two only resources. This is the best way to do this. I mean, hopefully that's like me going to the doctor and him saying, well, you're going to get a medication, but I'm not really sure what kind and I have no idea where it comes from. That would not be acceptable. So thank you for coming on and teaching people what to ask, you know, when they're calling a provider, what to expect, what not to expect, or what to make sure they're, you know, waving a red flag about. But how do people find you? How do people actually find you for this service if they need to?
My Instagram handle and Facebook is at Precision Regen Med. I have a pretty robust YouTube with at Dr. Tammy Penhollow, Dr. Tammy Penhollow, and precisionmedprp.com is the website. I'm teaching at places like Toby and participant at IOF and just got back from a musculoskeletal ultrasound regenerative medicine conference in Vegas this last weekend. So I proudly display those things on my website of where I'm going and where I'm getting trained and maintaining training. So that's how you find me.
Perfect. Thank you so much for coming on. Thank you so much for talking about this topic. I appreciate it.
It was my pleasure. Thank you.
Mm-hmm. That has been today's episode of the Scottsdale Top Docs Podcast. Catch you next time.
It starts with tremendous confidence. And I mean, somebody who comes to this thing not as a person who's taken a class or two, but somebody who's literally got their PhD. But that alone is not enough. I would say the second ingredient that Dr. Amber brings to the party is some empathy, but also the ability to nudge people and to get them going. And then the third piece that she brings, which is equally as important, is such a friendly demeanor and a smile. And she lights up our life every time she comes.